Welcome to the Evidence-Based Cardiology Talks, offers that curated view on global research, guided by expertise.
Can this common, pretty inexpensive drug, colchicine, actually help prevent future problems?
Right. And we've got some fresh data to look at, a big meta-analysis pulling together results from 6 major clinical trials. Patients were followed for, anywhere from a year up to nearly 3 years.
A much better picture of the sort of sustained.
Yeah. It suggests a pretty significant benefit. About a 25% reduction in major cardiovascular events for the folks taking low-dose colchicine long-term.
A 25% drop. Okay, that sounds like a big deal. Let's definitely unpack how they got that number and, what it really means.
Okay, well, first, maybe a little background. To understand why colchicine might even be on the table here.
Good idea. Because it's mostly known for gout, right?
Traditionally, yes, gout, pericarditis. But our understanding of heart disease, specifically coronary artery disease or CAD, it evolved.
Right, the inflammation angle.
Exactly. We now know inflammation isn't just a bystander. It's a key driver in atherosclerosis. It makes those plaques in the arteries unstable.
So it's not just plumbing, it's active.
It's active, yeah. And the CANTOS trial, that was really a landmark study.
I remember that one.
Yeah.
It showed targeting inflammation worked.
Precisely. They used an antibody targeting a specific inflammatory signal, interleukin-1 beta, and saw fewer cardiovascular events in patients who had high inflammation levels to begin with.
Measured by HSCRP.
Measured by HSCRP, high sensitivity C-reactive protein, yeah. That trial kind of proved the concept. But the drug used in CANTOS, well, it's expensive and not easily available everywhere.
Ah, okay. Which naturally leads to looking for other options.
Other, perhaps cheaper, more accessible anti-inflammatory drugs. And that's where colchicine comes back in.
Because it has those anti-inflammatory effects.
It does. It works differently, mainly by affecting neutrophils, those are a type of white blood cell, and reducing certain inflammatory messengers, cytokines like interleukin-1 and interleukin-6.
That is cheap.
And it's cheap, and we know it pretty well from its other uses.
It's interesting, though, because you mentioned guidelines. The European Society of Cardiology, their 2024 guidelines, already give it a recommendation, don't they?
They do, which suggests, there's already a decent amount of evidence backing it.
So that begs the question. If the guidelines are sort of leaning that way, why isn't it used more widely in practice already?
That is the million-dollar question, isn't it? And that's partly what this new meta-analysis is trying to reinforce or clarify, especially because a more recent trial, Clear Synergy, came out with results that didn't quite seem to fit the pattern.
Ah, okay. So Clear Synergy maybe muddied the waters a bit?
A little. It looked specifically at patients right after a heart attack, and it was done during the COVID pandemic, which might be important. But yeah, it didn't show the same clear win for colchicine. This meta-analysis helps put that single trial into the bigger picture.
Got it. So let's get into the meta-analysis itself then.
They followed standard guidelines for systematic reviews and meta-analyses, the PRISMA guidelines.
Okay.
They searched all the major medical databases, Medline, Embase, Cochrane, right up to November 2024. Plus, they checked reference lists of papers to make sure they didn't miss anything.
And they were looking specifically for trials in secondary prevention.
Yes. Patients who already had established vascular disease, so a history of heart attack, stable coronary disease, or even stroke.
And what kind of trials made the cut?
They needed to be randomized controlled trials, RCTs, the best kind of evidence, comparing low-dose colchicine, mostly 0.5 milligrams a day, against a placebo. And crucially, all patients had to be on good background medical therapy already, and the follow-up had to be at least 12 months.
Okay, so focusing on long-term use, excluding shorter trials.
Exactly. They wanted to see the sustained effect.
What were they measuring? What was the main outcome?
The primary endpoint was AE's major adverse cardiovascular events. It's a composite, a combination of things.
Right, that usually includes.
In this case, cardiovascular death, heart attack, MI, ischemic stroke, and urgent coronary revascularization needing procedures like stent or bypass urgently.
And they looked at those individually, too.
Yes, those were secondary endpoints. How colchicine affected MI risk alone, stroke risk alone, and so on.
And then they combined all the results. How did they do that statistically?
They used a standard statistical approach for meta-analysis, a random effects model, the Dersmonian and Laird method specifically. It lets you pool the results while accounting for the fact that the trials might be a bit different from each other.
Okay, makes sense. So after all that careful work,
Yeah.
the findings, let's revisit that main result.
Right, the big one. A 25% reduction in the risk of MACE for patients taking colchicine compared to placebo.
And statistically, You mentioned that hazard ratio.
Hazard ratio 0.75. And the 95% confidence interval was 0.56 to tomato 0.93. Since that whole range is below 1.0, it tells us the result is statistically significant.
So a real effect not likely due to chance. That 25% reduction is quite something. Did it affect all parts of NACE equally?
Pretty impressive reductions across several components, actually. They found a 29% lower risk of heart attack.
Nearly a third.
Yeah. And a 37% lower risk of ischemic stroke.
Even bigger for stroke.
And a 33% reduction in the need for urgent revascularization. And importantly, each of those reductions was statistically significant on its own.
That's very compelling for those specific events.
Yeah.
What about dying from cardiovascular causes?
That's where it's different. The analysis did not find a statistically significant difference in cardiovascular mortality between the colchicine and placebo groups.
Okay, so it prevents MIs and strokes, but doesn't seem to reduce deaths from heart causes based on this data.
Correct. That's what this pooled analysis shows.
Let's circle back to that clear synergy trial, the one that didn't quite fit. How did this meta-analysis account for that?
The authors discussed it directly. They pointed out, as we mentioned, it was done during the COVID pandemic. That could have messed with reporting, follow-up, maybe even outcomes.
How so?
Well, they noted a kind of weird finding in clear synergy. Fewer non-fatal heart attacks seem to correlate with more deaths from any cause. That might suggest some non-fatal events weren't captured properly, maybe because people avoided hospitals during peak pandemic times. It's speculative, but plausible.
That's a really crucial context. Any other potential explanations for the different results in clear synergy?
Another possibly very important point was about inflammation control. Looking at the hsCRP levels.
The inflammation marker.
Right. In clear synergy, the patients taking colchicine didn't seem to get their hsCRP levels down as low as patients did in the other big positive trials, like Colcott or Ludoco-2.
And why does that matter?
Well, it links back to CANTOS again. The idea there was that anti-inflammatory treatment works best in people who actually achieve lower inflammation levels on the treatment. Maybe that threshold wasn't consistently met in clear synergy.
So maybe the drug wasn't quite hitting the target effectively enough in that specific trial setting.
Potentially. But the key thing is, even with clear synergy included in the mix,
The overall results still held.
yes, the overall meta-analysis, combining all 6 trials, still showed that significant 25% reduction in MACE. So the weight of the evidence still points towards a benefit.
Okay. Now, one of the trials they included, CONVINCE, was different, wasn't it? It focused on stroke patients.
That's right. CONVINCE was unique. It enrolled patients after a non-severe ischemic stroke or a high-risk TIA, a mini-stroke.
And were these patients different from the heart disease patients in the other trials?
A bit, yeah. On average, a higher proportion of women in CONVINCE and more patients with high blood pressure compared to the CAD trials.
So what did the meta-analysis find specifically for preventing another stroke in these patients?
Well, looking just within CONVINCE, there was a trend towards fewer recurrent strokes and related events with colchicine, but it didn't quite reach statistical significance for stroke alone.
Not significant. Why might that be?
It could just be a matter of statistical power. Maybe the trial wasn't large enough or the follow-up long enough to definitively show a stroke-specific benefit, even if one exists.
But did they see any effect on inflammation in CONVINCE?
They did. They saw a significant reduction in hsCRP levels with colchicine in that trial. So the drug was doing something biologically.
Okay. So for stroke patients, the picture is maybe promising, but needs more research.
I think that's a fair way to put it. The authors concluded that more studies looking specifically at colchicine after stroke are definitely needed.
Makes sense. Now, safety. Always critical for long-term medication. What did this analysis show?
The safety findings were generally pretty reassuring. Across all these trials, they didn't find any significant increase in major problems like all-cause death, non-cardiovascular death, serious infections, pneumonia, or cancer with colchicine compared to placebo.
That's good news. Any downsides at all? Any side effects that trended higher?
There was a slight trend, not statistically significant, towards more hospitalizations for gastrointestinal issues.
Like stomach upset.
Things like that, potentially. But the authors noted the event rate was low overall, and they speculated, again, maybe some of those GI symptoms in the clear synergy period were actually related to COVID-19, which often caused GI upset.
Ah, another potential pandemic confounder.
Possibly, but importantly, there was no signal of increased risk for serious GI problems like gastrointestinal cancers or anything like that.
And given colchicine's long history for gout and pericarditis, does that add to the confidence?
It definitely does. We have decades of experience with this drug. And seeing it used relatively soon after a heart attack in clear synergy without major new safety flags popping up is also quite reassuring.
Did the benefits seem consistent across different types of patients? Did they look at subgroups?
They did. They looked at age, sex, presence of diabetes. Generally, the benefit seemed consistent. Colchicine appeared to work similarly well regardless of age, whether patients had diabetes, and in both men and women.
Although maybe less data for women.
Right. They cautioned that the analysis for women had less statistical power simply because fewer women were enrolled in the original trials overall. But based on the available data, no obvious difference in effect.
Okay. This sounds incredibly thorough, but every study has limits. Did the authors point out any limitations of their own analysis?
Yes, they were upfront about that. They mentioned seeing some statistical heterogeneity for certain outcomes.
Meaning the results weren't perfectly consistent across all trials.
Exactly. Which isn't surprising given the differences between the trials, slightly different patient groups, maybe different background therapies evolving over time, those varying inflammation levels we talked about, and definitely the potential impact of COVID-19 on some trials.
Did they try to dig into that heterogeneity?
They did sensitivity analyses, like they took out the convinced trial data and reran the numbers. They looked only at pre-COVID data, and generally the main findings held up, which adds confidence.
Any other limitations mentioned?
They noted that because of the way endpoints were defined sometimes, especially in Convince, they couldn't include all the event data in the main analysis, so they had to run some secondary analyses using slightly different statistical methods. Also, doing really detailed subgroup analyses was tough because the original trials didn't always report data in a uniform way, and with only 6 trials, some more advanced statistical explorations weren't possible.
All right, you need more studies for some of those techniques. Okay, so let's try and tie this all together. For someone listening, perhaps a cardiologist or someone just keen on staying informed, what's the main takeaway here?
I think the key message is pretty strong. This meta-analysis really firms up the evidence that adding low-dose colchicine, usually zero point 0.5 milligrams daily, to standard therapy significantly cuts the risk of having another heart attack, an ischemic stroke, or needing urgent stenting or bypass for people who've already got vascular disease.
A significant reduction in those major events. But, important caveat, no significant reduction seen in cardiovascular death.
Correct. That's a crucial distinction based on this evidence pool.
And the safety seems pretty acceptable for long-term use at these doses.
Yes. Overall, the safety profile looks reassuring based on follow-up extending up to almost 3 years in some cases.
So this really bolsters that whole idea of targeting inflammation in cardiovascular disease, doesn't it? And offers a tool that's actually affordable and widely available.
It really does. And while, yes, we need to be mindful of the nuances around the Clear Synergy trial, the pandemic context, the inflammation control aspect, the overall picture from these 6 trials combined is, I'd say, quite compelling.
This kind of comprehensive look at colchicine, digging into the meta-analysis, understanding the context, well, that's exactly the sort of in-depth analysis we aim for here on Evidence-Based Cardiology Talks. If you are a cardiologist or anyone involved in cardiac care, and you want to stay updated on the latest, most relevant journal publications across all sorts of topics in contemporary cardiology, we really encourage you to subscribe.
You can find Evidence-Based Cardiology Talks on Spotify and also on YouTube.
That's right. And just a reminder, this podcast is produced under the supervision of Dr. Caroli, who is a leading cardiologist. You can find more info at drcaroli.com.